Hi everyone, I am Dr. Anisha, your microbiology faculty, and the topic for today's discussion is going to be tuberculosis, wherein we will be talking about its pathogenesis as well as immunity in tuberculosis. So the very first thing that we must know about the causative agents of tuberculosis is that it is not just caused by one species, but it is an amalgamation or a complex of species which are responsible for this infection. So this complex is the Mycobacterium tuberculosis complex. And the species which are included in this complex are Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, 𝗕𝗵𝗵𝗂, 𝗕𝗅𝗵𝗵𝗀, and 𝗘𝗅𝗵𝗔𝗀, etc. So these are the most common species which are present in the complex, whereas there are other species like chimpanzee bacilli, etc. and some more species which are less commonly seen. Those are included in the complex, but most important ones are these, and these are the only species that you need to remember for the exam. And amongst these species, Mycobacterium tuberculosis remains the most important one and the most common species. Right? Then coming to the source of infection. So it is not just the only human source which is responsible for tuberculosis, but we can get infection because of bovine cases also, right? So the sources can be human. And which humans? These are pulmonary TB cases. First thing, and the infection has to be active positive pulmonary TB patients, and the bovine source because of ingestion of unpasteurized and infected milk of the cattle. So these are the two major sources of infections. Now coming to the mode of transmission, the first one most of us are aware of, that is inhalation. And what are we inhaling? We are inhaling the aerosols which are produced by positive pulmonary patients. And how are these transmitting the infection? It can be either by coughing, sneezing, or even speaking. So the next important thing that we must know is the size of the aerosol. So how are they very susceptible to such infections? Because of the size of aerosols, which is around less than 5 micrometer droplets. These are dry droplets which remain suspended in the environment, and these are inhaled further by other people in the vicinity. Infecting the patients people in vicinity. So this is one way of transmission. This is one mode. Then the other one we have already discussed. It is by ingestion. And one thing we are consuming is the unpasteurized milk, infected milk. And second thing that occurs in infants where they tend to swallow the sputum. And the third mode of transmission is going to be direct inoculation, where there is a direct contact with the skin surfaces of the infected patients. So, although it is uncommon to get tuberculosis by this mode of transmission, but it is considered to be one of the modes of transmission. Now, moving on to the risk factors which predispose the community to the development of tuberculosis. So, firstly, we have sputum positive patients. And who are these patients? They will be having acid-fast bacilli, which is detected in microscopy. So these patients are more efficient in transmitting infection than sputum negative cases. Then comes the bacillary load. So there needs to be an optimum amount of bacilli which is essential for transmission of infection, right? So what is this bacillary load? It is around at least 10 to power 4 bacilli per ml of sputum. This is optimum for the transmission of infection. One thing. Then certain patients having cavitary lesions, they will be having more bacillary load than the normal patients who do not have any cavities in their lung. So they will be having around 10 to power 5 to 10 to power 7 bacilli per ml. So naturally there are higher chances of transmission with more bacillary load, right? And then the third patient category, that is extrapulmonary tuberculosis and culture negative patients. These are considered to be non-infectious. They will not be transmitting the infection via coughing or sneezing, right? So this is important point for you to remember. Then overcrowding, all of us are aware that overcrowding is an important risk factor for transmission of infection because a lot of people will be inhaling or they will be inspiring those bacilli. So naturally there is more risk of transmission of this infection. Then low cell-mediated immunity, immunocompromised patients, and even most commonly HIV patients are more susceptible to development of tuberculosis, right? And then the age group which is most commonly affected, it is the late adolescents as well as elderly patients. And women of around age group, say 18 to 35, they are more susceptible, they are more at risk of developing tuberculosis. Then what are the important comorbidities which are associated with TB? Firstly, if there is any transplant that has occurred. Diabetes is an important risk factor. In most of the infection, diabetes is considered to be one of the most important risk factors. Then IV drug users, they become more susceptible to this. Then post-silicosis, etc. And any bypass surgeries, bypasses, these are all the comorbidities and other conditions which predisposes the individuals for this infection, tuberculosis. Now coming to the pathogenesis, so talking about the first mode of transmission, that is inhalation. So droplet nuclei are inhaled by the individual. So what usually happens in most of the cases, say in around 90% of cases, these droplet nuclei, they get trapped in the airways, and they are cleared by the mucociliary action. So they are cleared by ciliary action. They are never going to enter your lungs, right? But in around 10% of cases, these droplet nuclei are going to enter your alveoli. But it is important that all the bacilli which are entering inside your body, all the TB bacilli which are entering, are not always going to cause an infection. And this is what we will be discussing in the pathogenesis as well as the immunity. So once the TB bacilli, they enter the alveoli, the second thing that occurs is the adhesion to the macrophages. So now macrophages has two important roles to play. One is phagocytosis, right? And the other is antigen presentation for the immunity which is required in any such infections. So first thing is the macrophage, they need to get rid of that foreign body or the bacilli. So what usually happens, firstly, the bacilli outermost layer or the cell wall, there is one component of the cell wall which is going to get attached to the receptors which are present on the macrophages. So that important structure, it is the LAM or lipoarabinol. This is going to get attached to the complement receptors and mannose receptors present on the macrophages. And because of this adhesion, the bacilli are now internalized. Now the next step is phagocytosis. The macrophage needs to phagocytose the bacilli. So how is this phagocytosis occurring? This is occurring, or this is enhanced by the opsonin C3b. C3b mediated opsonization occurs. Which will aid in the phagocytosis, right? Then what is the next step? Survival in macrophage. Now once the bacilli that gets internalized in the macrophage, so what is the next step to get rid of that bacilli? It is the phagosome and lysosome fusion. Phago-lysosome fusion is going to eventually occur and contain the bacilli, and the macrophage is going to kill the bacilli. But that is not occurring in most of the cases. So what occurs, because tubercle bacilli, they are very, very efficient in transmission of infection. So what needs to be done next? So these LAN has been responsible for attaching to the macrophage receptors. So what is happening in macrophages? The phagosome and lysosome fusion is inhibited inside the macrophage. And what is that one important point which is responsible for inhibition of this particular phagosome-lysosome fusion? It is the lipoarabinomannan which is present on the surface of the bacilli. So usually what happens for the phagosome-lysosome fusion, there is increased calcium and increased phosphatidylioinositol. So this LAM is going to inhibit increase in calcium and phosphatidylioinositol presence or their concentration inside the macrophages. So ultimately what is happening? This fusion is inhibited. So as a result, what occurs? The bacilli, instead of getting destructed, these are going to survive inside the macrophages, and it is here where multiplication of bacilli occurs. So once multiplication of bacilli is occurring, so the macrophage, now they become saturated with the bacilli and ultimately they burst out and they expel the bacilli. And these bacilli are in any other way are going to be transmitting the infection or spread of infection. So this is how the pathogenesis works for tuberculosis. So let's see this with the help of picture. So in this image, first thing that is occurring is the aerosolization. Infected patient here, suppose this is the infected patient, he is sneezing or coughing, and this is the droplets, these are the droplets which contain the bacilli, right? So these droplets are anyway inhaled by another patient or another person which is standing, or the patient or the person is present in the vicinity. So inhalation occurs. So then the macrophage phagocytosis occurs because it needs to get the bacillary LAN needs to get adhered to the macrophage receptors, right? So now phagocytosis is occurring. So what is happening here? The bacilli, suppose this is the macrophage. So the bacilli are internalized inside the macrophage. And what is this structure which is formed? It is the phagosome, which is nothing but the phagocytic vacuole. So ultimately, next step that is occurring is the phagolysosomal blockage and replication. And in turn, there are certain other things which are also released during this process. What are those other things? These are the cytokines which are released, then more macrophages are recruited, then vascular endothelial growth factor is released, and these cytokines are going to cause the antigen presentation. This immunity part we will be discussing in detail in the later section, but this is majorly what is occurring. The cytokines are released, then the innate immune response occurs where a lot of recruitment of NK cells, T cells, monocytes that is occurring, and because of this immune response, granulomas are formed. And these granulomas will also have more angiogenesis, more blood supply. And this is how the whole of this picture continues, the cycle continues of the pathogenesis and the immunity. So the granuloma formation occurs, and at times when these granulomas are formed and when the immunity is low, so bacilli which are present inside the granulomas, they will be released, which will be responsible for the clinical manifestations of tuberculosis. Let us read that or talk about that in the later section. So to know about the pathogenesis and the immunity, we first need to know the cell wall components of the TB bacilli. This is the cell wall of Mycobacterium. So we have a number of structures, and in order to remember this particular structure, we have a mnemonic, that is PAM, LAM. Because cell wall structures are quite often asked as one-liner questions in your exam, so you must be aware of such things. So with PAM, with P, we have this is the peptidoglycan layer. This layer, this is the peptidoglycan layer, which forms the major structure and provides the rigidity to the cell. Then we have the second layer. This is the first layer. We have the second layer, which is the arabinogalact, which is also a structural component of the cell wall, right? P, A, and then comes the third layer, that is the mycolic acid. This is the waxy layer. They most often talk in the staining of TB bacilli. Mycolic acid, which is made up of long chain fatty acids, and then we have the outermost layer, which is majorly made up of mycosides and other lipids, glycolipids, etc. So this covers this part of the mnemonic, that is PAM-O, and the LAM we have already discussed. This portion, these areas, these are embedded in the plasma membrane. This portion is the plasma membrane, and this is lipoarabinomannan, which is responsible for a lot of important functions in the immunity and the pathogenesis, and also this is one of the most important antigen which is responsible for a lot of infections, and this antigen is useful in the diagnosis, in TB diagnosis as well. So these are the important structural components or cell wall components of TB. Now moving on to the immunity in tuberculosis. So we are aware that we have humoral immunity and cell-mediated immunity, but most of us might be aware that TB bacilli, it is an obligate intracellular organism. Intracellular organism. So humoral immunity has a very minimal role in its pathogenesis, right? But Th2 cell functions is that they are going to release certain interleukins, that is interleukin 4 and interleukin 5, which is going to stimulate, or they are going to ask the B cells to release immunoglobulins. Immunoglobulins which are important for the pathogenesis and immunity, right? The only role here of humoral immunity is the Th2 cells which are going to release two interleukins, interleukin 4 and 5. Now the other type of immunity here is the cell-mediated immunity. We have already discussed one of the roles of macrophages, that is phagocytosis, and the other role is antigen presentation. Antigen presentation. Now these macrophages are going to present antigens to T helper cells, which later activate into two subsets, that are Th1 cells and Th2 cells. Now the role of Th2 cells, we have already discussed that these are going to release interleukin 4 and 5, which in turn are going to activate the B cells and they are going to stimulate them to produce certain immunoglobulins. Now what is the role of these Th1 cells? Now these Th1 cells are going to produce two important things, that are interleukin 2 and interferon gamma. Now these two components are in turn going to activate the monocytes and macrophages, and their activation, it is going to produce two responses. One is the macrophage activation response, and the other one is tissue damage response. Now what happens in macrophage activation response? There is one important cell which is going to activate the resting macrophage. So we have the resting macrophage which is going to be activated by interferon gamma into activated macrophage. Now, these activated macrophages have the ability to kill the typical bacilli, but what they do, they aggregate around the central lesions, aggregate around the lesion, which leads to the formation of granulomas or tubercles. So centrally there is a lesion, and around that we have the aggregation of macrophages. So they lead to formation of granulomas or tubercles. Now what are these tubercles? Firstly, we have the hard tubercles and the soft tubercles. So these hard tubercles, they in central area, they have, suppose this is the central zone, we have two zones, and this is the peripheral zone. The central zone has activated macrophages, the modified cells, that is the epithelioid cells, plus the multinucleated giant cells. This is the central zone. Central zone. Later we have the peripheral zone, which is surrounding the central area, and this peripheral zone is comprised of the lymphocytes as well as fibroblasts. And in the central area, of course, we are going to have 𝗕𝗵𝗵𝗂𝗍𝗍. 𝗕𝗵𝗵𝗍𝗍. So what happens later, that these hard tubercles are going to transform into soft tubercles. So now what is the central area of soft tubercles? So this area, it is replaced by some caseous or cheesy material inside. Caseous material, and outside we of course have the epithelioid cells, the giant cells, the fibroblast, lymphocytes, etc. So this caseous material, which is also known as the caseous necrotic area. So this caseous necrotic area has low oxygen tension and low pH. So TB bacilli are not going to flourish, they are not going to multiply, and in fact they are not going to survive in this central area. So this is the soft tubercle which forms, and later this soft tubercle, it calcifies and contains the infectious material, the bacilli and lesions, right? So let us first talk about the important cells we have discussed about till now. We have spoken about interleukin-2, we have spoken about interferon-gamma. So interferon-gamma is one very important cell in the role of pathogenesis or tuberculosis. So this is going to produce all the important functions. This is going to be responsible for all the important functions of macrophages, their recruitment, their activation, etc. So that is why it is known as the most important cell, and the most important wrestler most of us might be knowing is the 𝗕𝗵𝗵𝗂𝗏, which was very important for the wrestling world. So interferon gamma is the 𝗕𝗵𝗵𝗏 of tuberculosis, right? Then we have spoken about interleukin-4, 5, which are going to cause the release of immunoglobulins, right? So now we have already discussed about the macrophage activation response, which is started or initiated by interferon gamma. Then we have the tissue damage response. Now most of the patients who get infected with TB, or they get the bacilli inside their respiratory tract, they are not always going to cause, or they are not going to be responsible for the transmission, or they will not contain the infection always. But in certain cases like low immunity, comorbidities, the caseous material which was present in the soft tubercle it is going to liquefy. This liquefaction of the caseous material will be responsible for transmission or spread of infection inside the body when there is low immunity or other comorbid states, right? So now, how is the spread occurring of this caseous necrosis? Direct spread occurs first thing, then the lymphatics and the hematogenous. How is the lymphatic spread occurring? Because of seeding to the same lung, later to the other lung, and finally to other organs. Now, direct spread is that caseous necrotic area will release a lot of bacilli which would be spread inside our body, right? Direct spread is occurring like that. Then the hematogenous, of course, via blood. It will be taken to different organs. And lymphatics we have already discussed. So this is how the immunity, the pathogenesis and tuberculosis occurs. And let us look at the pictures now. So this is the caseous necrosis, cheesy material. This is an image of a lymph node showing caseous necrosis. And are you able to appreciate these multiple areas of necrosis, these multiple small yellowish white areas? These are caseous necrosis which are comprised of the cheesy material. And this is the diagrammatic depiction of a tubercle or granuloma. Central area, of course, this central necrotic area. This is the caseous necrotic. Then around the necrotic area, we have the modified cells or the epithelioid cells. So are you able to appreciate these cells? And look at the shape of these cells. Do these cells have an appearance of a slipper? So these are known as slipper cells or epithelioid cells. Epithelioid cells. Here we have the Langerhans giant cell, multinucleated giant cell. Cell of TB. And the outermost layer, outermost covering, it is of course comprised of the lymphocytes and the fibroblasts. A real image showing the central area of caseous necrosis, necrotic area. These are the epithelioid cells. And these structures, these small structures are nothing but the multinucleated giant cells or Langerhans cells. And we are now able to appreciate the fibrous tissue comprising of the fibroblast and other lymphocytes. So these are the diagrammatic depiction of caseous necrosis which is seen in tuberculosis. And this was about TB's pathogenesis as well as immunity. Thank you.